And this is Hyeon-Cheol is from Borame Hospital. Is recently graduated our third-year fellowship. Okay, so Dr. Song, will you present the case history?
Yeah. Next slide. Okay. This patient was a 69-year-old male. He was suffered from exertional chest pain for 1 year. Echocardiography showed that normal systolic function without regional wall motion abnormality. He currently is taking antihypertensive and anti-diabetic medication. Next, please. Electrocardiography showed that the normal sinus rhythm without significant ST change. Next. Okay. Coronary angiography showed that the relatively normal looking right coronary artery. And left coronary angiography showed that the proximal to mid-RAD significant stenosis with ostium of diagonal branch stenosis looks significant. Okay, and AP caudal view showed that the focal tight stenosis of circumflex ostium.
So next. So my intention to prepare, intention to prepare this patient is the left main and LAD bifurcation with severe calcification, which can be possibly treated with rotablation. So we'll see. And issues here is how to overcome severe calcification and how to protect the side branch and how to optimize the main vessel stand expansion. Actually, we'd like to show today's angio and you will see more clearly about the calcification. Angio, please. Okay, this is epicranial view. You can see the calcification here, proximal LAD, the lining, not in one-sided. The opposite side of diagonal, it is the unilateral calcification. Above this, it looks like a bilateral calcification. That means angle is more than 180 degrees. And the diagonal ostium, not so severe, just 60% stenosis, but the risk of risk of compromise during the procedure. Next. Okay, RA crania more clearly visualize the LAD, just distal the diagonal. In this view, actually, calcification is unilateral, not the bilateral in the proximal LAD. Next. There is some left main disease, and the problem is that the circumflex ostium is about 75% stenosis. So 2011 bifurcation with severe calcification. So can I show you IVUS first? Do you want to see the IVUS first?
You mean the angiographic appearance of left main bifurcation is 011?
Yeah, maybe you think it's the 111 through 111, but the marginal,
I think this is clearly 111, not 0111.
Yeah.
When you look at the not apicodal view, in the epicranial view, show us the epicranial view.
Epicrania, yeah.
Look at the size of the left main.
Yeah, I know.
Distal to the
I agree that there is 40 to 50% stenosis, but it is not serious matter. That's what I mean, 011.
And just proximal to the bifurcation, there is some severe disease. Look at the vessel size and the left main body and the mid-area portion.
Area cranial, please.
So this vessel size in the angiographically looks like left main size angiogram itself is similar to the mid-area.
Yeah.
But the left main size should not be the mid-area. So
You're right. IVUS is
should
needed
be
to
more
identify.
larger.
Yeah, IVUS is very important to identify the vessel size. Yeah. So
Therefore,
another
this
point.
should be classified 111.
Another interesting one is just the distal mid-LAD. Just at the septal branch, you can see about 40% stenosis there. It's a little bit flexing. Okay, so maybe stent can be extended above this lesion. Ibis, please.
May I ask
This is-
about the size of the guider?
Guide 7 French. Actually, my intention was we need a rotablation. And if we need a rotablation, maybe we need at least 1.75 for proximal LAD. This is larger than 3.5. So at least I like to ablate about more than 0.5, 50% of the vessel size, port artery ratio. Otherwise, we do the radial approach most of cases.
Okay. Angiographic appearance is a really, really tough case.
Ibis, please.
Ibis, please. Plate. Ibis, plate. Ibis on the screen, please.
High risk of the complication or dissection or the
Yeah.
other complications, side branch, loss of
Yeah.
side branch loss. I agree. Very tough cases.
We have a technical problem of Ibis image. Ibis stop 해주고. Ibis 언제 되는데? 들었어요?
Just
Okay.
please do angio-guided PCI.
No. Actually, I strongly recommend the IBIS-guided PCI. Yeah, just Dr. Hong mentioned that the vessel size is tricky in the bifurcation. So this is distal. From the back.
디스탈.
This
From
is
the distal.
learning from the middle AD, right?
Yeah, running from medial AD distal to septal branch. It looks okay. Vessel size is just less than 3.0. This is the stenosis above the septal branch. You can see the 조금만 뒤로 가봐요.
다시 좀 뒤로.
You can see the bridging 또 위로 proximal. Yeah, bridging myocardium here. This is myocardial bridge, and 9 o'clock to 2 o'clock. So this stenosis is not so severe. So initially, I like to extend the stent down this lesion, but I need to skip it. So this is calcification just above the. This is just above the diagonal. Calcification is actually less than 180. It looks 180 here, the very short segment. The vessel size is 4. Lumen size 2. And this left main, calcium above about 180. Vessel size is 4 or 4.5. It's quite different IVUS compared to angiography. So we need to follow the vessel size dependent approach. Okay.
Intravascular images give us a lot of the information.
Circumflex.
When we look at the angiogram, as I comment that the left main size is looks like a smaller or comparable to mid-AD, but intravascular imaging, the left main lumen size quietly spared. So and then the angiographic appearance. There is the calcification looks like very heavier, but the IVUS image is not so many.
Yeah.
And that is another
Yeah.
message.
That was
And angiographic appearance of the mid to distal AD, there is some narrowing, but the IVUS finding that lumen area is more than 3.0, so your treatment strategy was changed just a little long,
Right. Yeah.
right?
Yeah. So I will show the IVUS from the circumflex. IVUS on the screen, larger screen, please.
Large screen.
라지 스크린.
This is a proximal circumflex. Vessel size more than 3, lumen about 3. And now it is approaching circumflex ostium. About 50% stenosis, very short, right? The shorter than I expected from the angiography. So maybe this lesion can be treated with only balloon. We don't need a stent for this case. But of course, we need to decide after the ballooning. And I can dilate a little bit aggressively because the lesion was not so calcified and very short. And lastly, I'd like to show the IVUS from the diagonal. Next. Diagonal distally branches to 2.0, normal looking. And approximately it's about 2. Not yet. It's about 30% stenosis, vessel size 2.0, up to 3. It's approaching the ostium. Yeah, very short, eccentric, about 70% stenosis there. So this is also very short. So initially, angiographically, I decided to rotablation for LAD and possibly for circumflex. I really like to show you how to perform the rotablator very easily within 5 to 6 minutes, but it's not good for this patient. I'd just like to show you how to treat the two bifurcation together. So actually, the next question I'd like to discuss is to treat the two bifurcation. Do you start from the distally or do you start from the left main? Treat the left main bifurcation, then LAD, or the opposite? What do you think?
I do not clearly understand how do you fixate the two bifurcation?
Yeah, that's the
Mid-LAD
question.
diagonal, 2 stent or 1 stent, and the left main bifurcation, 2 stent or just 1 stent?
Do I have to say now?
My strategy is just stent from left main to mid LAD, then see the circ and diagonal and ballooning, and see the angio, and final kissing balloon and finish. Or side branch may be treated with DB.
Yeah. So
What's your plan?
So my plan is just to finish with one stent technique, and but the size discrepancy of a medial LAD to proximal LAD, I just put the 3 stent with the middle to proximal LAD, and treating the circumflex with the balloon. Maybe we need a predilation there, and I don't think DB is working here because the vessel is very short, very small. And then put the 3.5 stent and to the cross the left main, and circumflex I tried to finish with a drug-eluting balloon. The issue is that I don't use the kissing balloon. So that means the repart technique. That means if I do the LAD, I do cross the stent, then the further dilatation just proximal to diagonal. If needed, we do the side branch ballooning, undersized ballooning, most likely 2.0. Then post dilation again. So side part, I prefer. Then there is a lot of discussions about comparing the final kissing ballooning versus the repart technique. So maybe you can choose either
I
way.
agree is the simple method to solve the two bifurcation. I agree.
Just move,
Okay.
not only saying, just move. Okay?
So how many minutes do we have? 2.0, 2.5
2.5 balloon.
20mm balloon.
이-
How long do we have?
Will you do the
좀
predilation?
Oh, now. I didn't do that yet.
No, what I mean is you will have a plan to the dilate?
Predilation for the diagonal. For
Diagonal.
2.0. Because a predilation doesn't hurt as far as that we have no dissection. The important thing is try not to dissect the diagonal. That will have a problem. Okay, 2.0, 2.5.
네, 245.
Okay, areocranial. So procedure became much simpler.
Would you consider the two-stent technique? Because
No,
I'm
test.
not sure
Test.
the
Inflation,
Inflation.
of,
10,
10,
DB
10,
the circle orifice is good long-term follow or not.
deflation,
deflation.
So, Dr. Wang, do you recommend two-stent technique for left main bifurcation
10,
area?
10,
Yes, I will consider use
10,
Curoy
14,
or
14, 14,
Koch technique to
Deflation.
protect
Deflation.
the circle orifice region.
18,
Because
18.
in Taiwan, actually, the DB
18.
is not
okay. Deflation.
embraced by
Deflation.
national interest in
엔저 찍어놓고
negative lesion. Only
테스트,
테스트.
can use it in the ISR region.
엔저
엔저.
준비,
For the distal
Shoot.
small vessel disease,
23,
sometimes we use the
3.5,
but for the
3.0이 좀
orifice,
클려나?
circle orifice,
2.75.
worry about
2.75, 23.
다이고널
of
볼론이 갈
the
거예요.
DB.
2mm 볼론,
2mm 볼륨.
Dr. Kwon considered just ballooning at circles because
Right.
it is really focal lesion. Thus,
Yeah.
he does not consider stenting to the focal stenotic circles. But even though it is focal and at the ostium, it is not fully expanded. We may have to
Yeah.
add stenting.
yeah. I follow the provisional approach for bifurcation. So if needed, we can put the stent anytime. Epicoda? No, sorry. Epicranial. I dilated LAD and diagonal. It's kind of risky testing
테스트.
of dissection. That's what I really don't like to do. Like make 2.
2.
Very slow
Actually, his
inflation.
view is not good for
Two.
the overlap the guiding caster with a balloon and the lesion.
218.
But I can see clearly the
4,
bifurcation.
18.
4, 4, 4, 4,
네,
4,
4, 4입니다.
6,
6, 6,
8,
2-0 balloon.
2, 0.
Eight.
I just like to open. And long inflation. To reduce risk of dissection, actually. Slow inflation, slow, long inflation.
Dr.
Deflation?
Kwon,
deflation.
Yep.
if you can finish the whole procedure in a single long take, then we just maintain you're alive.
How long?
Or we have to move to Jeonnam National University.
Yeah, this is up to you. Up to you. So,
Okay, then 20 minutes
저거 저
past.
스탠드
It's
23.
75, 23.
275, 23.
You can leave me anytime. If you don't love me.
or
Okay.
just find a kissing balloon of 2, 3, 5 balloons. Okay, we are going to leave you and turn to the Samsung Medical Center. Good luck to
예,
you.
거의 다 끝났어요. 좀만 계시게. 미드 LAD가.
Okay.
Okay, Dr.
Okay.
Gwon, we are seeing
Yeah.
now.
I am regretting very much because we do the procedure for 5 minutes and waiting for 50 minutes. So, Angel, you okay? I dilated the LAD with the 2.5 balloon to 2.5, 20, the 10 atmosphere, next. Upper part, 14, next. Lastly, the 18 atmosphere, then next. Then next. So I pre-dilated the diagonal. But there is some debate about the benefit of a pre-dilation. But anyway, the data shows that it's not harmful if there is no dissection. Next, 2.0. Then stent Zion's Sky Point 2.75, 23 millimeter, 12 atmosphere. Next. Then flow was actually decreased diagonally. Next. So I rewired it. We checked the diagonal. The flow is marginal. So now we can post-dilate the proximally part. then side wiring is possible. The recommendation from the EBC, but I prefer just wire and then part. Next. Yeah, I pull out wire. Next. I use wire prolapse technique to avoid undermining of the wire to the stent. And from distal to proximal pullback and push to the diagonal is very useful technique. Next. So angiography with wire, this flow was delayed. Next. So we dilated very slowly with the 2-point balloon again. Next. So it was improved, flow was improved, but still we have about 70% residual stenosis. The option is now that we have a kissing ballooning next, but I prefer repart with the same balloon. Next. So a little bit more compromise of the diagonal ostium. So do you want to find a kissing ballooning for this lesion?
Yeah, most physicians prefer final kissing balloon to open the diagonal os.
Actually, first side branch ballooning didn't improve much. The flow is okay, so I decided to leave it alone. Okay, next. So I pull out wire. Next. Next. And 뭐지? The sizing the left main, left main stent 23. So I chose 23, 3.5, 23 stent forward. So I stopped there.
I think before the removal of the wire in the diagonal branch, you'd better the more high pressure, particularly in the just distal to the diagonal branch. Angiographic appearance, there is some narrowing. So when you do the IVUS after the post PCI, there is some on the side of the stent. At the time, you need the high pressure.
Actually, so I don't care much about the diagonal. The flow is okay. The data shows that there is no problem. So if aggressive dilation with diagonal will compromise LED stent, that will be the problem.
No. I do
diagonal?
not comment about the not diagonal branch. I think the diagonal branch is okay, but the
LED? LED,
yes.
as I showed
Look at
you,
the angiogram.
as I showed
Just
you,
distal to the diagonal
I know.
branch, a little bit narrowed, caused by the severe calcium.
in the medial LED,
And
just
look at
above
the
the
size
septum,
of
septal
the
branch.
vessel size and the more distal LED.
Distal LED.
So you mean that the stent portion is a little bit under-expanded expectation. So after the end of the stent deployment, please tell us the final lumen size.
Oh, sure. Stent expansion. Okay, you're right.
So
you're right.
before the wire removal, I'd better to the high pressure.
Yeah, I got
in
the point.
distal parted,
I got your point.
and then
So, I mean, the plate.
inflate that, and then removal of the
The opposite
diagonal
side
branch.
of diagonal, there is a stent under expansion. If we like to stent well expanded, there is a risk of side branch. This is a trade. So I need to check the IVUS at the after the main stenting. Definitely, we need to take care of that. Okay, just the stenting test. To the 조금 밀고 테스트. 이 정도? 잘 안 보인다, 그죠?
네, 오래
좀.
Yeah, it is overlapped.
네.
Inflation. 10.
You can do the
14.
the stent and the proximal LED and the left main in the cranial projection. But if you do that, the younger interventionist learn that
Deflation?
and the similar way of it. Usually, proximal vessel intervention was recommended. Is not cranial view. Total
But I should recognize the clear location of the stent position. And I like to post-dilate, test,
Test.
post-dilate here, test.
Test.
Maybe without wire is kind of dangerous, but the EBC recommended post-dilation test.
Test.
Okay, here, inflation,
Inflation.
14,
14. 14.
16.
16.
Okay. There's some under-expansion in the distal part, deflation.
Inflation.
Epicaudal. 스텐트가 18 했나? 14 했나? 제일 처음에.
처음에
12.
12.
So test.
Test.
The circumflex was okay. Inflation
Inflation.
18, 20.
18. 20.
Deflation.
Inflation.
Okay. So maybe this is not usual practice of yours, but I do it routinely like this.
Now you are doing a very cost-effective procedure. Not use
Oh, LED.
the high-pressure balloon.
Okay. Good. So
It is not
next,
recommended in
yeah.
the interventionist who does not have much experience.
I'm not sure. So now we have challenge to rewire the circumflex. The optimal approach is that,
네.
okay, let's do the optimal approach. 4.5 balloon,
4.5.
post-dilation,
Part.
then rewire the circumflex.
Before that, please show us the angiographic
Yeah.
appearance.
Sure.
How much the circle was compromised?
Yeah.
Not much compromised. Give me 3 flow.
Compromise very much. So I like to rewire first. So actually,
What
it
is
is
the
recommendation.
purpose of the rewiring of the circ?
Yeah, there is a risk of wire undermining, right? But the EBC recommend part first, then rewire. Theoretically, in many times it works, but Dr. Gu and I don't like that. So there is definitely there is risk of compromise the circumflex during the left main part. So I like to rewire. Oh, this is a lady. Poke.
Okay.
Yeah. Easily.
Anyhow, the strategy for the very complex and high-risk patient, Dr. Gwon fix it just a simple
Yeah.
and safe way. This
Yeah.
is
That's
the
what I like to
educational
show.
message to the audience.
That's what I like to show. So it gotta be some wire prolapse here. Anyway, going
You
to
do
LED.
that, such kind of the young
Spider view?
intervention, the wire out, and then the retry of it, and at that time, loss of the total loss of the circ.
Test.
So before that, use the another wire.
Test. This is that's not a problem with expert or beginner because flow is compromised either way, apicaudal in the expert's hand or beginner's hand. That's
One of the reasons why he
This the decision-making.
he recrossed the circ with a wire. The
Yeah.
reason why circ flow is good.
yeah, right. That's right. That's the issue of decision making, not the expert beginner issue. So maybe we are not sure about the location of the wire. Maybe we can check the IVUS very shortly about the possible undermining. Actually, wire prolapses in the left main. I'm sure that this is true inside the stent, but if that is not, I'm not sure. So I check it with IVUS.
What is your next step?
So balloon side branch and the part
Before
and
that, before the part, please show us the IBIS image, and then if you have a plan to the part,
oh
and
really?
what is the change after the part
Okay,
for the educational
Okay.
purposes.
okay. I'm doing the IVUS from the LED to left main.
From the what about from the mid LAD, or we wanna. I want to know about what is the minimal
Areocranial.
lumen size of the
Okay.
minimum stent
Okay.
area at the mid LAD.
Okay, I'm doing that.
Okay, pull back.
Pull back. This is the white breaching, just distal to LED. Then comes a stent here. Not well opposed, right?
That is
Yeah.
the importance of
Yeah.
the
Right.
intravascular imaging.
Yeah, but the length of a malposition is not so long. But if IVUS size, actually, we should have done the 3.0 rather than 2.75. Anyway, this is round. Oh, only the diagonal side is passed. Anyway, this is proximal LED. Then left main
네, 썩.
wire is inside, right?
예.
Really?
Please analyze what is the minimum
Yeah, this is
stent
underexpanded.
lumen area and the mid LAD portion and the left main. What I mean is left main is have a huge lumen size. Why do we have a part?
Huge lumen size is malopposed.
Yes, to relieve the malopposed portion, you
Yeah.
will do a part. I agree.
Yeah.
Yeah, I think we need a port for the lemon region because it's under expansion.
Right. Yeah. Of course, we need expansion. So 4.5,
4.5.
5.0 maybe. 5.0. The vessel is getting large. 저거 IVUS에서 diagonal side 반대쪽 좀 찾아줘봐요. Just distal to the diagonal.
Okay, grab.
The most proximal several stent strut is not opposed to left main
Apical.
wall.
Yeah. Right.
Thus, you are going to do a part using 5.0 balloon.
4.0 now. So
4.0
vessel
balloon?
size measured in IVUS of 4.5, but the vessel is getting large. But usual practice is actually after part we do the IVUS, but the education purpose. Okay, thanks. Test.
Size
Okay.
size for
Inflation.
the balloon selection to fix
10.
the malopposed
10.
portion.
Yeah.
We need a lumen
14.
size,
14.
not the vessel size.
Yeah, of course.
You know that the malopposed
18.
portion was usually in the normal reference vessel.
Difference,
So just
deflection. Part is too proximal.
Tender touch and just attach it.
Test.
Test.
Okay. Inflation.
Inflation.
4.
4.
Slowly is slipping.
4.
8. 10.
8.
14.
10. 14.
Yeah. EBC is slipped already. Okay, deflation. So more proximal. It's 10. Length to 10.
8.
8.
Yeah.
8.
Why 8?
Too short.
Test.
Test.
Inflation.
Inflation.
18. 8 is
18.
too short. Yeah, deflation.
Inflation.
So issue here is the circumflex is compromised, and left main stent is well opposed. Yeah, shortly I check circumflex. Yeah, flow is okay.
5 minutes left.
Okay. Then I skipped IVUS and 2.5 balloon.
2.5 balloon.
지금 4.5 balloon 좀 15mm짜리 좀 구해주세요.
아.
와요?
4.5, 15.
8mm 너무 짧아.
Do you have plan to do final kissing balloon?
No. Test.
Test.
Inflation 4.
Inflation. 4,
10,
10,
12.
12.
4.5, 10.
I'd like to finish with repart. Part, side, part. Deflation.
Deflation.
The issue is that we need a DB here. And first we check there is no dissection. If there is dissection, we need a stent here.
4.5, 10.
네, 0.55.
Okay. But there are a lot of residual resonances. Spider view?
You create some dissection.
No.
The proximal circ,
No, I don't think
not
so.
the ostium.
Just inflation? Sure. No
There
dissection
is some
actually.
haziness.
Right.
Just
Okay, we need
what
a
about
stent.
in the retrospectively,
Yeah.
just let it alone is the best option.
But I think I need a stent here.
Okay.
So previous view?
Previous.
DB. What do you think, Dr. Song? DB or DS here?
I think the tap.
Huh?
Tap with it.
To stent?
Yeah.
Hmm.
There are some heaviness on the proximal portion of circumference.
Okay.
Yeah, I'm also agree with
Yeah.
yes. Thank you.
The length가 아까
2.5 블룬.
2.10
저거 15면 될까?
어떤?
3.6, 15?
아, 오케이. 3.0,
저
15.
볼론 좀 줘봐요.
블룬 2.5,
Yeah,
20.
let me
25.
check the length of the stent by the
예.
balloon.
2.5, 20.
2.6.
3.0, 15, 18 준비해요. 오케이.
네.
연결할 필요 없고
네.
AP 코드 테스트
테스트.
here 18 오케이. 야
탭이니까.
15
15.
yeah.
3, 5.
3, 0, 15 Okay, I didn't like to show you the two-stand technique. It's my secret, but that is no option. Yeah, spider view. The important tip for tap technique is the location of the proximal end of stent. So we did a stent in left main. You clearly see the ventral side of the stent. So then actually we need a balloon, stent balloon,
스텐트 발룬.
3.5 balloon.
3.5.
3.54.
And always put the balloon, left main balloon inside just a stent
3.5,
balloon.
24.
잡고.
좋았습니다.
It is very important to find the projection angle that avoid
그
overlap
네거티브 좀 걸어주세요.
between
네거티브.
left
아,
main and
생하지
circ
말고
ostium.
생 잡아 이거.
네.
네거티브 걸어주세요.
Otherwise, we can lose the coverage of circ ostium.
오케이.
이렇게 LED.
레디.
LED를
So start the balloon. Okay, there. Then pull out the stent. Test.
What
Test.
size of circ stent?
Yeah, 3-0.
3.0.
Yeah. 잠깐만 준비. Shoot. Yeah, I think this is okay. A little bit to 1 or 2 millimeter protrusion. 약간 pushed. Yeah, 4. Slow inflation
예.
is the key.
이렇게 4,
6,
6,
8,
8,
10,
10,
12.
12.
Even
Okay.
though you try to the accurate position of
Deflation?
the stand in the provisional stand, during an inflation process, there is some the backward motion.
Yeah,
So nobody
Inflation?
can sure that the
Yeah, I can show you.
minimal
18.
protrusion
18.
18.
it
But
can be
but I can
easily
show you the minimal
visualized
protrusion.
at the
Deflation?
Inflation.
intravascular ultrasound.
Yeah,
That
of
is
course,
the reality
yeah.
of the
Yeah.
provisional tap technique.
In our series, actually, IVUS
Angiographically
measurement of
acceptable.
protrusion was the 3.5 millimeter in our series. Inflation, both 8, 6, 6,
6.
6,
6까지.
6,
10,
10,
10,
12.
12,
12,
Okay. Circumflex 14,
14,
16.
16.
Okay, deflate.
하나,
둘,
둘,
셋.
셋.
I agree with the increase more pressure at small balloon at circ.
And actually, I added 18 atmosphere at ostium or circumflex. Always, circumflex ostium is undersized. Angel?
안정.
Shoot. Still undersized, right? Maybe it cannot be corrected. Maybe we have to do the very difficult to do it. LED.
Okay, do you plan to do adjunctive ballooning at circ
Yeah,
also?
yeah. Circumflex 18.
18,
And time's up. What's your
20.
final plan?
Final plan, kissing ballooning and IVUS and finished project. Deflation.
Kissing ballooning, IVUS, and the final
Yeah.
part?
Inflation.
inflation.
Final part is not necessary.
Not necessary. Okay.
10,
10,
12.
12,
Okay.